Thanks so much, and thank you for a really inspiring start to this conference. I'm looking forward to seeing the rest of it. Yeah, the Tiger and Aladdin. That's yeah, I'll be talking about basically work that I'm doing with Dr. Srivastava, who's here with us, basically in that large our large clinic at Boston Children's Hospital. Someday I'm going to have to put real disclosures, but until then, I'm going to have fun with it. It is not going to affect my findings or my, or there's no conflicts of interest here. So a brief outline of what we'll talk about. So the introduction is not really needed for this group, but I'll still give a short one. And then I'm going to focus on three aspects. The first one being the neuropsychological profile of Kleefstra syndrome, by which I really mean more IQ. And then looking at psychopathology, different psychiatric conditions that co-occur in Kleefstra syndrome, upon treatments that have been used and what has and has not been effective. And my hope is that exploring this sort of question through retrospective chart review can not only inform clinical practice, but also help generate hypotheses for future work. So to start, like I said, introduction not really needed, but mutation in euchromatic histone methyltransferase 1. There is a, so there is a known clinical. I want to point out that there is a large phenotypic variance as well. And so there is this characteristic appearance described, but as has been published and as you all know, there is one size does not fit all here, and that's going to be a recurring theme in this presentation. So this is 2 Brookline Place, where we see our patients with KS, and as you've heard, we have seen over 125 patients. Specifically, we have seen 126 patients, which is greater than 125. If you haven't seen this paper written by Zoe and others, I really encourage you to look at it. It is basically, this is work from last year where we went through, we really looked at phenotype-genotype correlations in our clinical cohort and go through a lot of the different manifestations, including developmental, and you can see kind of between patients who have a sequence variant, basically resulting in a missense mutation, can often have a quite markedly different phenotype than patients who have deletions. And then even with patients who have deletions less than 1,000 base pairs, and those that have more than 1,000 base pairs do have different profiles. And also, there are other comorbidities. So here are some of the neurologic comorbidities, including epilepsy, sleep apnea, microcephaly, cortical visual impairment, and then some of the systemic difficulties these patients have, including cardiac conduction abnormalities, constipation, thrombocytopenia, and not necessarily, not all patients have these, some do, and the genotype does influence this. And recently, we came out with a paper looking at the infant and toddler developmental profile. And again, was really looking at different language and motor domains and comparing it by genotype. And what you see is, so developmental quotient for those of you who are, oh, cool. For those of you who are don't regularly use this term, it's basically what is their developmental age over the expected the development at their expected chronological age. So in these domains, visual, motor, and language, you see that we're really hanging between 50 and 60 on average, which means that developmentally, someone is about half the chronological age where you would expect them to be. And similarly, when we look at more specific motor milestones, you see the age of achievement of these milestones is later than in a typically developing child. So first words is around 25 months. We really expect it 12 to 18 months in most children. Similar with walking. And so that's an example there. And then if we actually compare, then we actually look at genotype, we do see, again, a difference. And so left to right, so the sequence variant, the smaller deletion and the larger deletion, and we see that in general, the age of achievement tends to be, on average, earlier for patients with sequence variants, with deletions, and in some cases, such as walking and rolling, even later in patients with large deletions. So that's just setting the stage to kind of my own particular interest, which is kind of looking at the interaction between the genetic condition, neurologic symptoms, and psychiatric symptoms. So in doing this, I looked at 80 individuals. So you notice 80 is less than 126, and this will be updated. So this is kind of the first round. I'll be looking at additional patients that we have here, and the median age was around, although quite a range, 1 to 37 years of age, and a small majority had sequence variants, but a good amount had deletions as well. And so, first of all, and this is not something that's particularly, this is something that's fairly well known, but the patients who have deletions do tend to have lower IQ on average than patients with sequence variants. And it's not an insignificant difference. If you look at the range of each, there actually isn't overlap. And so with basically patients with deletions having mild to moderate intellectual disability, and then patients with sequence variants being in the no intellectual disability to mild. One thing I will say is that you may notice that I don't have large deletions here, and that is because we just did not have this on chart review. There was not full-scale IQ testing done on patients with large deletions. I can speculate as to why that is, but we don't have that at the moment. There might be in the upcoming sample. One thing I noticed is that looking at the subdomains, there did seem to be a relative strength of verbal comprehension and fluid reasoning relative to some of the other domains like visual working memory and processing speed. I couldn't actually do statistical testing on that because it's not, so if everyone got a particular type of test, like the Wechsler Intelligence Scale for children, that would be one thing, but we're talking Wechsler children, Wechsler for adults, Stanford, Binet, and the subdomains don't exactly line up. So that's a potential future direction to look at. So what does it mean in practice? So of course there is the prognostic element, the type, so the genotype can help determine what one's functioning is going to be. I do think the question of relative strengths is worth looking into. So we know that for some conditions, there are some patients who have what is called a nonverbal learning disability, where basically their verbal functioning is good, but their visual spatial function and that sort of thing is very poor. And so oftentimes a way around it is to really put everything in terms of language, really take that math problem and make it into a word problem and that sort of thing. And if that does bear out in a more standardized way, then that could help children with KS maybe access education better with classroom accommodations. And so that one thing I would love to see in the future is, in natural history studies and prospective studies, really kind of standardizing neuropsychological measures and including some other tests aside from IQ testing, including like going deeper into specific domains of language function and that sort of thing. So that's the first part. Now looking into psychiatric comorbidities, so there's a good amount and they affect a significant number of our patients. And I will say that the four most common ones, so ADHD with a narrow lead, but aggression and anxiety behind. And I don't need to tell you this, sleep disruption affects a lot of individuals. And regression is also quite high. And so one thing, and this one I also compared between genotypes, and most of them, there was no difference. There was 2 conditions where there was a significant difference, and that I think is interesting. And patients with sequence variants actually had significantly greater incidence of anxiety symptoms and ADHD symptoms. And so I'll talk about why that might be in a bit, but I also want to point out the regression. So as was pointed out, this often happens in, this is a pubertal thing that happens, and this is borne out in ours as well. And the median age was close to 14 years of age, although there is variation here as well. And it has kind of followed that character of often the sleep disturbance is kind of a harbinger, and then followed by regression, loss of skills. And so just thinking about why anxiety and ADHD symptoms are more common in patients with sequence variants, it's a bit of a chicken and egg thing. One could argue that perhaps a patient with higher cognitive functioning is going to be more aware of distractions and potential dangers and that sort of thing, thus having greater anxiety and ADHD symptoms. I suspect probably it's the other way around more so. We know that in patients who have lower cognitive functioning, we are often missing anxiety and ADHD symptoms because it's not necessarily looking like what we learn about, and patients aren't able to necessarily express their concerns. And so that's something to think about potentially for the future as well. I wanted to kind of, thinking about how to sort of handle this, I really like what has been done in tuberous sclerosis complex. So we know that in TSC, there are certain psychiatric conditions that are highly associated, autism, ADHD, learning disabilities, and that sort of thing. And so a formalized checklist has been formulated to basically guide patients and clinicians during visits to track longitudinal symptoms, and also help remind providers to not lose track of these, because in many conditions, even patients with even conditions with severe neurological, often the mental health aspect that is more debilitating and troublesome throughout one's life, and so it's important not to lose track of it. I know that as we further characterize KS, I could easily see something like this being handed to families at the beginning of a clinical visit and helping that guide management. And so finally, I wanted to look at different types of pharmacotherapy that has been used and basically see how effective it has been. And so this is kind of this is part one of a large table, but looking at individual symptoms, seeing how many of them, one, did they receive pharmacotherapy, and two, of those, how many of them seemed to be helped by the pharmacotherapy. And you can see that it's inconsistent, but we do see that ADHD is relatively well treated, and that's not entirely surprising. In psychiatry, ADHD is one of, if not the most treatable psychiatric symptom. But then other symptoms, aggression, irritability, anxiety, helped. Some are helped, not all. And I will point out, of course, that the sample size is small, so it's hard to draw definitive conclusions from this. Other symptoms, kind of similar, like there's variability, small sample size. Mood cycling seems to have good effect, but it's only 2 patients. But one question I had is, on review, there is a lot of different classes of pharmacologic medication used for different types of symptoms. And it was interesting to sort of think about, well, is there a particular one within a class that's a better choice than others? And so what I did is I just went through the different classes of medications and basically split them up arbitrarily into medicines that I called basically ineffective, so none had documented good results. Ones that had low efficacy, so less than a quarter of patients who got it had a positive response to it. And then everyone else, I didn't want to be too unrealistically optimistic, so I call it some efficacy, but basically more than 25% had some sort of response. And so I'll go through each of them quickly. So basically, alpha agonists, so guanfacine, clonidine, neurologists and psychiatrists really like these medications. They're pretty benign and can treat a variety of symptoms. Unfortunately, not super efficacious. Guanfacine a little bit more than clonidine. Antidepressants, there was a very interesting sort of dichotomy between, like, most of them did not really do much. Fluoxetine, Prozac, the oldest SSRI, which, you know, is really effective in most people with major depression, really didn't help much. Sertraline, Zoloft, seemed to help more people. Antipsychotics, and really we're talking about atypicals. There weren't any first-generation antipsychotics used in our patients. So we know that olanzapine has been shown to be helpful, but interestingly, quetiapine and ziprasidone has also helped somewhat. Omeprazole and risperidone were used more, and that's not surprising in patients with autism. These are the two medications that are FDA approved, and so they're often the ones we reach for first. Speaking in terms of proportions, not as effective as these, though, which I can speculate on that in a little bit. As far as non-benzodiazepine anxiolytics, small sample size, but buspirone seems to be helpful. Hydroxyzine, not very helpful. And then going to the benzodiazepines, lorazepam did seem to help one patient, clonazepam not so much. And I'll tell you, just looking through these a lot, these were basically used because with regression nowadays, we really have to think about, is catatonia the underlying thing that's going on? That's a whole hour-long plus discussion on its own, but it seems like in this case, the benzos have not been super effective in helping regression symptoms. And another thing you also have to think about, I'm going to jump down here, is regression actually due to an autoimmune condition? Because that can happen too. Someone with an encephalitis can certainly have regression in symptoms. Only one patient received immunotherapy, and they received quite a bit of immunotherapy, but it didn't really make any sort of difference. Looking at some of the other classes of medications, so stimulants, again, that doesn't really follow a particular pattern. I will say, I would love to say that, oh, the methylphenidates work and the amphetamines don't, but there's a little bit of each in there. And then of mood stabilizers, anti-seizure medications, topiramate was helpful, not for mood though, it was actually helpful for binge eating disorder because topiramate does cause appetite suppression. And then the other thing I'll point out, which is this other category. So there was one patient, and this was a patient who, when they came to us, they had previously tried this, but they had been given carbidopa, levodopa, basically for motor symptoms, and then it was found that they actually had improvement in other cognitive symptoms as well. Unfortunately, then they developed mania as a side effect, so they had to discontinue it. But that was kind of unexpected, and I'm not quite sure what to make of it, but an interesting potential future question. And then N-acetylcysteine, so those of us in neurodevelopmental disabilities like it because it's very mild side effect profile. And it can sometimes be really helpful for body-focused repetitive behaviors. So this was mainly prescribed for skin picking and hair pulling. It was helpful for one patient with hair pulling. So this is the one instance where I used AI in this project. So I thought to myself, well, maybe there's some sort of underlying unifying mechanism that actually helps tell us why one medication works and one doesn't. I can't really say that was successful looking at this. So if we look at, say, so there's no medication where all of the rows light up, because then I would say, aha, that's the receptor we should target. A couple of things I will note, though. I mean, so sertraline, this is actually, AI is not infallible. So sertraline does do a little, even though it is a selective serotonin transport inhibitor, it does actually have some mild dopamine transporter activity as well, more so than say escitalopram, so that's worth thinking about. And then I will say olanzapine and quetiapine, one I think important similarity that they have, and ziprasidone also, is this histamine H1 receptor antagonism. So if anyone is prescribed this medication, you know that one of the big side effects is it makes you tired. And that's largely due to activity. And part of me wonders, given that so much of the regression is characterized initially by sleep disturbances, does that play a role in it? Now, you'll notice that another medicine that I listed, hydroxyzine, didn't help, and that is an antihistamine, so it's not as simple as that. But is there some combination of serotonin 2 receptor plus D2 receptor plus H1 that seems to be effective? So the key takeaways, I've qualified it endlessly, so I'm not going to qualify it again. But in my view, it seems like some of the more promising medications for mood symptoms are, so I'm probably going to be reaching for Zoloft first. And for regression, I'm probably going to be reaching for olanzapine and quetiapine first. And then there are some other medications that I think are worth looking into further. So what is this with Sinemet? What is going on with buspirone? And I'm very excited to see the results of some of the drug repurposing studies that are being worked on, because there could be some real help here. So future directions include biomarkers of basically drug action and receptor functioning. My PhD background is in PET, so I'm partial to it, but I know that's logistically very difficult. But there could also be surrogate markers such as EEG. There's some interesting work on looking at electrical signals that correlate with PET measures, and so that could be an easier way to get at it. So my take-home points is that there is a neuropsychological profile, and it does vary by genotype. There are a lot of mental health concerns in these patients and these families, and even though no medicine works, there's no magic bullet, but some of them do seem to. I think that's worth pursuing, and I think that as we go forward, taking mental health into account as we have standardized assessments is going to really help us going forward. So some acknowledgements. So Dr. Srivastava is here with us. He runs the Kleefstra Syndrome Clinic. Zoe, who's also with us. And then Shauna Yu, a fifth-year child neurology resident at Boston Children's, was the lead author in the Early Developmental Profiles paper. You might ask who that is. That's Tamar Katz. She saw she's a psychiatrist at Boston Children's, and I literally can't find her picture anywhere. So I assume she doesn't want it up, so that's her. Actually, her hair is not, that actually kind of looks like her hair. Okay, and here are some references for your interest, and I'm happy to take questions.